I'm very happy to share this webinar with stalwarts like Christian Morgenstern and Dr. Ganchai. It was a fantastic talk delivered by Christian, highlighting what endoscope can do for all kinds of spinal problems. I mean, for us as a no voice, probably to understand that the endoscope is a useful tool in interlaminar surgery is very well known in stenosis. But for transforaminal decompression of stenosis, we are a little bit of in confusion of how this could be effective. To understand the philosophy of how a transforaminal decompression with an endoscope would be helpful in stenosis. So I'm giving you this talk with different kinds of tools that are available from the Maxmore system. We also help develop few new tools for decompression of stenosis. So rather than giving a live talk, I have recorded a talks which could be easily translated for you to understand it better. So I would request the organizers to start with the video, and I'll be there to answer all your questions. Thank you. First of all, I would like to thank that you gave me an opportunity to speak on this platform. So today I will be speaking on pathoanatomic and pathophysiological basis. So pathoanatomic and pathophysiological basis of transforaminal endoscopic decompression in spinal stenosis. Now we all know that conventionally we have been doing spine surgeries with the posterior approach for stenosis, but this is a new way, new perspective that we are looking at transforaminal surgery. So before we go into the details, let us go a little bit about the background. Now the spine that we all know about, the canal, which is more wide in the center, you can see that the canal is very wide in the center, and the part of the area which is more lateral, this area of the spine is the narrowest part of the entire spinal canal, leaving apart the foramen. So if at all a compression has to occur, the compression occurs more in the lateral side, and it is the superior articular process which is involved in the whole process. The inferior articular process gets involved in the pathology much later in the whole problem, and it gets involved when you have more of instabilities, or it gets involved when you have more of degenerative listhesis or something like that. So the narrowest part of the spinal canal is placed more laterally, that is just medial to the foramen, that is the lateral recess. So we have to understand the pathophysiology, that the Kirkcaldy-Willis diagram, where you have the posterior joints and the anterior intervertebral disc. So there is a simultaneous pathology going on anteriorly as well as posteriorly, and it is a complete degeneration that is occurring in the disc as well as in the posterior areas, which initially, after you have all the problems like annular fissures, disc herniations, internal disc disruptions, and on the other side, you have synovial reactions, cartilage destruction, and osteophyte formation, and loose bodies, and then starts with the process of subluxation. In the process of subluxation, what you have is a lateral nerve entrapment. Now, lateral nerve entrapment is part of the secondary or grade 2 disc related disorder. That means you have an initial part of a disc herniation and annular fissures, and then over a period of time you have the development of stenosis, which the first symptomatic thing is going to be the entrapment of the lateral nerve. So we need to see what is happening with the disc in the natural course as you are aging. So from normal to annular fissures to internal disc disruption to disc resorption, this is the natural course. Everybody, me and you, all have annular fissures in our life which spontaneously heal, and we do not go into a condition called as an internal disc disruption. But in some unfortunate, This does not happen the way we look at a normal person, but there is some amount of invagination of the proteoglycan, which is the nucleus in these annular fissures, and gets into a condition called IDD. All of us are going to get into the condition called as disc resorption. And when you have resorption in the disc, there is formation of traction osteophytes. And these traction osteophytes, if they are in a precarious area, may contribute to stenosis, may contribute to tethering, may contribute to pain. Now, when you have a degeneration, there are a couple of movements. Now, the degenerative process predominantly is posterior related. That is, the posterior column is involved, but the anterior column also contributes a lot to the entire process of degeneration. So when you have a posterior degenerative process going on, there are a couple of things that are happening with the facet joint. So you can have a superior inferior subluxation of the facet joint, wherein there is an incompetency of the facet capsule, and you also have the incompetency of the posterior annulus. And you get into a situation where the tip of the superior articular process gets into the upper part of the foramen. The second kind of an abnormal movement that is occurring is because of the capsular laxity in the facet joint and the incompetence of the posterior annulus. You have an anterior or a posterior subluxation of the vertebrae. And the third thing that is happening is during the collapse, you have rotations in the vertebrae. So when you have an opposite direction or correspondingly opposite movements in the superior and the inferior vertebrae, then you have what is called as a rotational element, which is seen that the superior articular process comes in the canal and traps the traversing route, which is contributing to the whole symptomatology. So these kind of degenerative processes are simultaneous processes and are not like separate, but they all occur together. And that is one of the reasons why we find not only collapse of the disc, but we find that there is rotational element leading to a lot of degenerative scoliosis. Now, one important thing that is contributing to the whole problem is the ligamentum flavum. The ligamentum flavum by and large is of three different varieties. One is type A, B, and C, whereas the type B and type C is the ligamentum flavum which gets into the foramen and in the extraforaminal region. And these are the patients who are more vulnerable for stenosis. So some patients where you see the MRI pretty degenerated, but these people do not have stenotic symptoms, is probably because of the reason that the ligamentum flavum is not as bad or not extending completely into the foramen and the extraforaminal region. We need to understand the ligamentum flavum pretty well, that the ligamentum flavum starts in the midline, goes along the lamina, then it crosses over and blends with the facet capsule and comes out of the foramen and then continues as an intertransverse ligament. So the superiorly, the ligamentum flavum is attached to the inferior border of the cranial pedicle and to the tip of the superior articular process. And then the medial margin, the deep layer of the ligamentum flavum is attached to the medial margin of the superior articular process. So when you have a degenerative process going on in the facet joint with abnormal movements, that is superior inferior subluxation or rotation or anterior and posterior, the ligamentum flavum also correspondingly moves with the facet. And that is the thing, that is one of the reasons why ligamentum flavum is being pulled. Now, what we call it as ligamentum flavum hypertrophy is primarily not hypertrophy, because in the body, no ligament hypertrophies. They all atrophy, but there is no hypertrophy in the ligament. So when you see a thick ligamentum flavum, it is probably mucoid degeneration of the ligamentum flavum and not actual hypertrophy. So the ligamentum flavum can be very beautifully imaged on fusion MRI and CT images. I'll not get into the details of that. Let's come to the pathology. Now, as I told you that the ligamentum flavum starts from the center, goes into the behind the lamina, and then comes into the foramen and continues extraforaminally as the intertransverse ligament. Now, we all know from the morphologic studies that the interpedicular distance, that is the distance between the medial wall of both the pedicles, is on an average about 24 to 26 millimeters. So, on one side, you have the ligamentum flavum or the interpedicular distance, which is about 12 millimeters on an average in Asians, and maybe a little more in the Europeans. But when you measure the cadaveric studies, from the cadaveric studies, the measurements reveal that you have as much ligamentum flavum extraforaminally as much as you have it in the canal. So the extent of the ligamentum flavum from the medial border of the pedicle to extraforaminal region was measured 11.9 millimeters, which is practically the same what you have it within the canal. This says that the ligamentum flavum is one of the important pathoanatomical structure, which may contribute to stenosis in all the patients. So there was a very nice study published in 2005 in the European Journal of Spine, and you can see that the part of the pedicles and the posterior lamina is taken off completely, and you see the imprint of the ligamentum flavum is in the axilla. So it is involving only in the axilla. You do not see any imprint of the ligamentum flavum in the center. So this is the pedicle up here. This is the L5 root which is coming out. This is the traversing root S1. You see the ligamental flavum imprint only in the axilla. Nowhere else do you see any imprint of the ligamentum flavum. So here you can see the dura mater in the center, the ligamentum flavum imprint, the pedicle up and pedicle down. So the important point to stress here is, when you see the process of stenosis, it primarily starts involving the axilla. That means in the axilla, the roof of the axilla. We already know from various cadaveric studies and from our experience with endoscopy that the floor of the axilla, which is also called as the hidden zone of McNabb, is also a favorite site for multiple pathologies like end plate spurs, bone osteophytes, and it can also be because of the annulus, which is bulging because of the collapse. So you have something coming from the dorsal aspect, which is primarily the ligamentum flavum, and you have something coming from the ventral side, which is primarily the annulus and various osteophytic growths. Now, a little bit to stress about what is happening with the ligamentum flavum and why the lateral nerve or the traversing nerve gets involved in the whole pathophysiological process. Now, this is a normal ligamentum flavum which is adhered, but when you have various rotational elements and collapse, this ligamentum flavum is pulled on one side or this side. So when you pull ligamentum flavum from both the sides, it is going to come down like this, like a tent. So when it comes down like a tent, the thecal sac compresses and pushes these two nerve roots away into the lateral recess, more and more into the lateral recess. So in severe cases, it goes so underneath that it is not only the ligamentum flavum which is causing the compression, but it is also the bone, that is the roof of the lateral recess, which is superior articular process compressing the root. So in a normal sagittal section, if you see, the ligamentum flavum is attached to the tip and to the inferior part of the cranial pedicle. So when you have a rotational element, say for example, when it rotates either clockwise or anti-clockwise, the attachment of the ligamentum flavum, which is at the tip and to the medial wall of the superior articular process, pulls the ligamentum flavum either from the canal or from the extraforaminal region into the foramen. And this pulling of the ligamentum flavum causes not only lateral stenosis, but also starts causing foraminal stenosis. So multiple pathologies are working at a time, biomechanics are working at the same time. So there is a process of degeneration of the ligamentum flavum, development of osteophytes, and there is a corresponding instability, that is micro instability being developed, and subluxation of the facet joint, either superior inferior, either anterior posterior, or in the form of rotation, causes the whole ligamentum flavum to come in the lateral recess and in the foramen. So by and large, the whole pathology looks to be in the lateral recess and the foramen. Now, if you see, this is a normal ligamentum flavum, but when this subluxation occurs, this ligamentum flavum, which is attached to the tip, is directly pulled cranially. Not only cranially, but also is pulled here. Now, this part of the ligamentum flavum will come from within the canal. So when you pull this ligamentum flavum over a long duration of time, there is mucoid degeneration occurring in the substance of ligamentum flavum, which looks or which is seen on the MRI as a hypertrophied ligamentum flavum. But actually, there is no such hypertrophy occurring because ligaments don't hypertrophy. Now, if you look into the neurological claudication, which is a typical or pathognomonic feature of any kind of a stenosis. Now, stenosis can have two different kind of symptomatologies. One symptomatology is it completely depends upon where the compression is. If the compression is at the level of the dura, you will have more claudication. If the compression is at the level of the root or the perineurium, it will be more of numbness and pain. So there are two different varied pathologies of where the compression is occurring. So it is not mandatory that all stenosis should have only claudication and numbness and no pain. You can have pain. The second reason for pain is when you have a vascular ischemia because of venous engorgement, you have an ischemia which sets in, and ischemia will put in all kinds of inflammatory mediators, which is shown here. So when you have a mechanical force, there is a subarachnoid space obliteration causing circulatory disturbance, breaking down the blood nerve barrier, intraradicular edema. It is something like a compartment syndrome within the root, and you have deep muscular pains. And you can also see these kind of abnormal discharges on the EMG and the nerve conduction. Now, this paper has been stressed and overstressed and has proved that more and more of compression is in the axilla and not in the central part of the canal. So it is necessary for us to think all these days when we are talking about central canal stenosis. Is it the kind of central canal stenosis are we talking about, or is it bilateral lateral canal stenosis that we are talking about? So there is an entity called as central canal stenosis. Probably it is a wrong terminology that we have been using all through till now. So what was found is, when you do an experimental clipping of the root, you have a Wallerian degeneration distal to the root. This is all known, but you also have Wallerian degeneration going more proximal because of the typical location of the neurons, which are called as the pseudo-monopolar axons. Because of these axons, you not only have distal but a proximal degeneration in the root. And this is probably responsible for some of the central symptoms that the patients get. So when you look into the pathology here again, so you see this is the nerve root which is going on. This is the superior articular process which I have marked in green. And this is the whole area. This area of the thecal sac or the canal has wide area which is more towards the center here. So all the pathology is all because of the osteophytic growth of the facet joint here and osteophytic growth of the facet joint here. The central part of the canal is always open like this. This does contain ligamentum flavum, but the ligamentum flavum just doesn't hypertrophy. It is all because of the movement that is occurring in the facet joint. So the pathophysiological process of stenosis is primarily in the plane of the facet, and disc contributes to it. Whereas it is not a complete pathophysiological process of the disc, it is the facet joint. So if we have to image stenosis, we should image stenosis in the plane of the facet and not in the plane of the disc, which we do it for most of the disc herniation. So if you image it in the plane of the facet joints, you will see ligamentum flavum, the extent of ligamentum flavum, and the amount of compression that is being created. And this kind of imaging is done with oblique coronal imaging, which is the sequence used for sacroiliac joints. So this is the kind of osteophytic growth, and this is all around the axilla. So there is nothing happening in the central part. You don't see much osteophytes here. All the osteophytes are located more laterally. And that brings us to an understanding that stenosis is probably more lateral pathology than considering it as a more central pathology. So this is all part of the stenotic pathology. So what are the strategies when you want to deal with the stenosis? The strategy is going to be all the pain generators or all the pathoanatomical structures which are responsible for the stenosis. One is superior articular process, foraminal ligaments, ligamentum flavum, disc herniation or annular bulges if there are any, pars defects, osteophytes, and in some cases facet cysts. So these are the primary involvement. So you have to deal with these structures if you are dealing with stenosis, not the central canal. So in transforaminal endoscopy, this is the center and this is the medial pedicular border, and this is where we land with our endoscope. So if I'm landing here with the endoscope and I know that there is no pathology here, all I have to work here in the lateral recess, in the foramen and in the extraforaminal region. We also have to remember that the medial wall, the medial pedicular border, that is, if you come midway to the pedicle, this is an area which is devoid of ligamentum flavum. You hardly have any ligamentum flavum, little ligamentum flavum or no ligamentum flavum, and that is what you see here, that you see the bare bone. Rest everything is ligamentum flavum. So if you are able to reach, if you have to go more caudal, able to reach half of the caudal pedicle, by and large, your extent of decompression for that level is very good. So this brings us to the idea that the extent of decompression for an unilateral problem, if you are going transforaminal, would be from the tip of the superior articular process to half of the caudal pedicle, and which we have been using this as a guide all through with our open surgeries also. And we also use this kind of a decompression even for interlaminar surgeries. So the extent of decompression is pretty well known. So what all things you can do? So this is in the lateral recess. You can see the traversing route here. And what I see here is this is the exiting route, which you can see some fat here. This is the part of the ligamentum flavum and the imprint of the ligamentum flavum towards in the axilla. So if I take this off and see, this is the exiting route, this is the axilla, and this is the imprint of the ligamentum flavum. Now, if I am able to take off this whole ligamentum flavum till I am able to see the exiting route, axilla, and the traversing route in one single vision of my endoscope, by and large, I will be able to decompress this entire area completely. I may have to go more medial, which is not a problem because I am already getting more dorsal to the nerve root. Now, to get more dorsal to the nerve root, I have to extend the foraminotomy a little more dorsal. Now, one may have an argument here that when you are trying to get in more dorsal, you may destroy the joint. Well, we need to also understand one thing, that the joint at the level of the disc is only about 40 to 50% of the facet joint. Rest of the joint is at the level of the pedicle. So about 50 to 60% of the facet joint is at the level of the pedicle, which is the strongest part of the joint. So even if you void the joint at the level of the disc, it is not really going to cause any kind of an iatrogenic instability here. So now you are able to see the exiting route and the traversing route. There's still a lot of ligamentum flavum which is coming from the dorsal aspect, which needs to go away. Multiple tools can be used here, including laser, radio frequency to shrink. Then you can use the Kerisons. So with the help of these multiple tools, you should be able to take off by and large a great amount of ligamentum flavum, which is there. So if you take off all this ligamentum flavum, this is the transmitted pulsations of the dorsal root ganglia. This is the traversing route, and here embedded in the fat is the exiting route. So I take off whole of this, and you will probably see in one single vision of your endoscope all the three structures: the exiting route, the traversing route, and the axilla. So if I so this is the holmium YAG laser that I'm using here. And now when I turn, this is the exiting route, this is the axilla, and this is the traversing route. I can take off more ligamentum flavum if I think that the traversing route is still compressed. Now, in situations where you have a mid-zone stenosis of the lateral recess, so this is the entry zone where the traversing route starts getting into the lateral recess. The medial to the pedicle is called as the mid-zone. Now for the medial part, in some cases where you have a collapse, the mid zone can be involved with compression, and also the part of the lamina part of the superior articular process can be involved. Now in that situation, this is a trajectory that we designed and we call it as the phorecesoplasty. That means you are not only dealing with the tip of the superior articular process, we are also dealing with the base, that is the overhanging part of the superior articular process, till you reach the caudal pedicle. So this is going to be the kind of trajectory that you are getting inside. So it is going to be from cranial to caudal, from lateral to medial, till you reach the paracentral region. Now technically, this is a trajectory which is little different, because the moment you are medial to the medial pedicular line, caudally you are going to be very close to the traversing root, as traversing root comes very close to the pedicle caudally. At the level of the disc, the traversing root is midway between the medial pedicular line and the midline, but caudally it is very close. So when you do this, the drilling part or the amount of bone that you take off from the roof, that is going to be the lamina part of the superior articular process, the part of the vertebral body which is probably the end plate osteophytes from the end plate of the inferior vertebra, and the medial wall of the pedicle, all needs to be taken out. So in the upper part, you are primarily able to take off the ventral part, that is the tip of the superior articular process. In the middle part, at the level of the disc, you'll probably be able to take off part of the inferior articular process and part of the superior articular process. And inferiorly, you will be able to take off the medial overhang of the superior articular process. So these are the various tools that we designed with Maxmore. So these are the original tools of Dr. Thomas Hoogland's design. So it starts from 4 millimeters to 9 millimeters, a completely a traumatic tip, and you are able to cut bone more comfortably. The new kind of drills that we developed are conical drills like this, which is cutting only in the 30% of the entire circumference. Now, because of this, you can direct the smooth part of the drill towards the spinal canal and use not complete rotatory movements, but jogging movements in an arc, so that 90 degrees arc, so that you are able to take off the overhanging part of superior articular process, which is the lamina part of SAP, the medial wall of pedicle, and caudally the part of the vertebral body. And we call this as phorecesoplasty, because we are dealing with the foramen, we are also dealing with the lateral recess completely. So this is the kind of surgery that we developed. So here I'm guiding the Tomshidi needle more caudally. Now it doesn't look to be more caudal because we have not corrected the lumbar lordosis. So if you have not corrected the lumbar lordosis, it looks more parallel. But when you see the lateral, you know that we are already touching the vertical body. My target here is going to be to reach the middle of the caudal pedicle, which I will do with my drills. So I'm taking my drills gradually, step by step, till the time I reach the medial pedicular border. You can go with your regular Tomshidi drills, Maxmore drills. But the moment you are more medial to that, then you have to shift to a more traumatic drills, which will make it safer for the patient. Second most important thing is the patient is again awake and aware, so he is going to report inadvertent pain. And third, in the stenosis pathology, there is going to be this mucoid degenerated ligamentum flavum, which is going to protect the root caudally. So once you have done the cranial part of the decompression, that is going to be the axilla and the roof of the axilla, you will proceed the way you would do it otherwise. But caudally, since once you have drilled it, you have already reached half of the caudal pedicle. You have already taken off a good amount of the lamina part of the superior articular process and the medial wall of the pedicle, which usually generates sufficient amount of room there. So the kind of drills that we use there are 8, 9, 10. You may go larger, but it is not necessary, because an average size of the lateral recess is about 5 millimeters. So even if you are able to generate about 5 millimeters of space, that's good. So this is the SAP, this is the pedicle that you see, and the part of the vertebral body which is gone. I'm putting in a 3 millimeter instrument just to check whether the decompression is easy. So I'm able to put the 3 millimeter instrument without any hindrance. This tells me that I am pretty well decompressed. So what am I able to cut when I'm doing this procedure? So this is the kind of cut. So you take off a part of the SAP and then you take more medial and then more ventral part. So this is the kind of cut that you are able to take off. This is the enlargement. So you take off part of the pedicle, you take off this roof, and you take off this vertebral body. So the trajectory from the inferior side is going to be something like this. So it is coming from lateral to more medial, reaching the paracentral zone. So, and this is going to be the trajectory. You can see the way the trajectory is going. So the trajectory is going like this, creating more room. So you can cut this, you can cut this, and you can cut this more medially when you reach half of the caudal pedicle. So this is going to be the root here. So when you put your Tomshidi drills, that is the safe drill, DDM drills, you direct the smooth part of the drill towards the root and the sharp part towards the bone, and you can turn it in 90-degree arc to gradually go inside and take off this part. So what these are some examples of some CT scans that we did in a couple of patients, and you can see the lateral recess on the contralateral side. This is the lateral recess on the ipsilateral side of our surgery. So this is pre-op. So this is post-op. This is the contralateral side, and this is the ipsilateral side. You see the amount of room that I have created here. Now, once you reach this area, you have taken out a good amount of bone. These drills don't cut ligamentum flavum, and ligamentum flavum needs to be taken off with Kerrison rongers or laser. You can see this overhanging part of the superior articular process here. This is the inferior articular process. Now this overhang of superior articular process is completely gone here. It is not seen. This is the medial part of the pedicle, that is medial most bulging, which is reducing the interpedicular distance. And this is the part of the medial part of the pedicle, which is now gone. And this is the tip of the superior articular process here. And this is the tip of the superior articular process completely gone. So you are not only able to do an anterior posterior decompression, but you are also able to take off part of the medial wall of the pedicle, which makes it one of the kind of procedure where you are enlarging the whole lateral recess in both the planes. So it is going to be anterior, posterior, and medial and lateral. Sorry, not medial, lateral. So what do we need to do is we need to think, are we doing the right kind of a surgery for all the patients? I'm not denying the fact that the patients who have bilateral symptomatology with predominant compression coming from the dorsal aspect, interlaminar surgery is the choice of the procedure, and transforaminal surgery cannot replace it. But when we have a problem more ventrally and with the patient having unilateral symptoms, which most of the patients start off having with the unilateral problem. So you can do an unilateral decompression for these patients under local anesthesia with the patient completely awake and aware. If a patient is not fit to undergo any kind of an interlaminar procedure because you require anesthesia for that, you may attempt it in stages also. But if the patient is by and large fit, you would want to do a procedure in a single stage, and interlaminar will be a choice. In cases where there is a concomitant foraminal and extraforaminal stenosis, because soft tissue could be bone, could be soft tissue, then the choice of procedure again is going to be not only that you take off the lateral, decompress the lateral recess, but you also decompress the foramen and the extraforaminal part. Thanks a lot for your patient listening, and thanks a lot for giving me this opportunity.